In this video, we will study about the vascular lesions of the head and neck region. The contents are introduction, classification, diagnosis, vascular tumors and vascular malformations, and lastly, the management part. Coming to introduction, so the vascular lesions of the head and neck, they can broadly be divided into two groups. They are the vascular tumors and the vascular malformations. These two terms are completely different. So you have to understand what are vascular tumors and what are vascular malformations. So as the name suggests, vascular tumors are basically they are true neoplasms and they arise from endothelial hyperplasia. So we know that endothelium is the layer of the blood vessel. They line the blood vessels. So if there is hyperplasia of the endothelium, that will lead to a formation of neoplasm. That is known as vascular tumor. Whereas vascular malformation is something else. The malformations, they are congenital lesions. They are congenital lesions of vascular dysmorphogenesis. That is, there is some problem related with the morphogenesis of the vascular structures, and they arise because of errors of the embryonic development. But these lesions exhibit normal endothelial cell turnover as compared to vascular tumors. In case of vascular tumors, the normal endothelial cell turnover is absent because they are basically neoplasms. But vascular malformations, they are not tumors. They are simple dysmorphogenesis of vascular structures arising because of some kind of embryonic maldevelopment, and they exhibit normal endothelial cell turnover. So it is not related with any kind of it is not related to any kind of hyperplasia of vascular structures. It is only related with morphological alteration of the vessels. Here again we have enumerated the differences between vascular tumors and vascular malformations. Vascular tumors, they are abnormal endothelial cell proliferation, whereas vascular malformation are normal endothelial cell turnovers. Vascular tumors have rapid growth. They are not associated with thrill and bruit. So thrill and bruit we test during auscultation. So for vascular tumors, along with inspection and palpation, the other important thing that we have to do is auscultation. They usually undergo spontaneous involution. So this point is very crucial. What does this mean? This means that as the patient develops or as the patient grows, the lesion slowly involutes, that is, the lesion slowly resolves. They commonly recur and more commonly affects females compared to male. Now let's look at the vascular malformations. So as I have told, there is only dysmorphogenesis of the vessels, not associated with endothelial cell turnover, any deformity related to that the cells are completely normal. These lesions, they grow with the patient. So as the patient grows, the lesion also grows. So they are present since birth, they are congenital, but initially it is not so much evident because the lesions are so small. But as the patient grows, the lesions become bigger in size. So we get to know it much later in life. Okay, and these lesions produce thrill and bruit compared to the vascular tumors. Vascular tumors do not produce thrill and bruit, whereas vascular malformations, they produce thrill and bruit. They do not involute. Okay, they do not involute, that is, they do not resolve with age, rather they grow with age. Recurrence is common. Recurrence is uncommon in vascular tumor, whereas recurrence is common in vascular malformation. Coming to classification of vascular lesion, The first classification is anatomicopathologic classification. So this was the earliest classification which was given by Virchow in the year 1863. So what he did, he classified vascular lesions into two categories. They are angioma and lymphangioma. So from the name only you can understand that angioma is related to blood vessels, whereas lymphangioma is related to lymphatic vessels. Now angioma is subdivided into angioma simplex, angioma cavernosum, angioma racemosum. Angioma simplex means system which is composed of capillaries only. Angioma cavernosum means a replacement of normal vasculature with large channels. Angioma racemosum means tissue which consists of markedly dilated interconnected vessels. Okay. Now the biologic classification. It is very important from examination point of view. The biologic classification was given by Millikan and Glowacki in the year 1982. So they classified vascular anomalies into two categories, that is hemangioma and vascular malformation. So what are hemangiomas? Hemangiomas are tumors. Okay, they are benign tumors. These hemangiomas, they demonstrate endothelial hyperplasia. We will look at malignant tumors also. But as per Millikan and Glowacki classification, the vascular anomalies are simply classified into hemangiomas and vascular malformations. So hemangiomas are tumors or neoplasms, and the vascular malformations are divided into low flow lesions and high flow lesions. The low flow lesions are the capillary lesions, lymphatic lesions and the venous lesions, whereas the high flow lesions are arterial lesions, arteriovenous lesions, capillary lymphatic lesions, capillary venous lesions, lymphaticovenous lesions, or capillary lymphaticovenous lesions. The vascular malformations have normal cellular turnover, whereas hemangiomas have abnormal cellular turnover. In the year 1996, the classification given by Glowacki was further modified by ISSVA. What is ISSVA? It is again very important. ISSVA stands for International Society for the Study of Vascular Anomalies. So they have modified the previous classification. So the ISSVA differentiates vascular tumors from vascular malformations. They have straight away given a difference. They have straight away given some variations between they have listed these variations between vascular tumors and vascular malformations. So let's look at what are the variations or what differentiates between these two things. So they classified vascular tumors into few categories and vascular malformations into few categories. First of all, we will look at vascular tumors. So the vascular tumors are infantile hemangioma, congenital hemangioma, caposiform hemangioendothelioma, spindle cell hemangioendothelioma, and tufted angioma. So these are the vascular tumors. They are true neoplasms. Whereas vascular malformations, they classified vascular malformation into slow flow lesions, high flow lesions, and combined lesions. The slow flow lesions are capillary lesions, venous and lymphatic vascular malformations. Okay. Whereas the high flow lesions or the fast lesions are arteriovenous malformation and arterial malformations. And we have certain combined vascular malformations. So this is the ISSVA classification of vascular lesions. In the year 2018, they revised the classification again. So let's look at the revised classification. The revised classification states that the vascular tumors are divided into benign tumors, locally aggressive or borderline tumors, and malignant tumors. Examples of benign tumors are infantile hemangioma or hemangioma of infancy. Then we have congenital hemangioma. Examples of congenital hemangioma are rapidly involuting, non-involuting, and partially involuting hemangioma. Then we have epithelioid hemangioma, spindle cell hemangioma, tufted angioma, pyogenic granuloma, and others. Examples of locally aggressive or borderline vascular tumors are caposiform hemangioendothelioma, retiform hemangioendothelioma, papillary intralymphatic endothelioma, composite hemangioendothelioma, caposiform sarcoma. It is associated with AIDS. Okay, and then we have others. HIV AIDS, caposiform sarcoma. This Kaposit sarcoma, it's a kind of vascular tumor. It is a potential MCQ for your upcoming NEET exams. Then we have malignant vascular tumors. They are angiosarcoma and epithelioid hemangioendothelioma. Now let's look at vascular malformation. Vascular malformations, they classified them into simple, combined, of major named vessels, and those that are associated with some kind of anomalies or syndromes. Now let us look at some of the few vascular, simple vascular malformations. They are capillary malformation, lymphatic malformation, venous, arteriovenous, and arteriovenous fistula. Then we have combined. Then some of them are related with some kind of major blood vessels. Then those related with syndromes, like we have Sturge-Weber syndrome, which is a very common syndrome you will see in your textbooks. Then Matthew's syndrome, Proteus syndrome, Parkes-Weber syndrome, and so on. How will you diagnose a case of vascular anomaly? How will you understand whether it is a case of vascular tumor or a case of vascular malformation? Because depending on your diagnosis, the entire treatment plan will change. So let's look at diagnosis first. You have to take proper history, clinical examination of the patient, MRI with IV contrast agent, Doppler ultrasound, CT angiography. Let's look at infantile hemangioma and congenital hemangioma. What is the difference between these two? Suppose a patient comes with you and your differential diagnosis, your provisional diagnosis comes out to be hemangioma. How will you understand whether it is a kind of infantile hemangioma or it is a kind of congenital hemangioma? Okay, so the infantile hemangioma is the most common benign tumor in children. Just remember this thing, it is the most common benign tumor in children. It is present shortly after birth, that is during the 1st and 4th week of birth. That is, you can say immediately after birth, when a patient is still in the infant stage, during 1st and 4th week of birth. And females are more affected than males. It has 3 developmental phases: proliferating, involuting, and involuted. The proliferation phase lasts till 1 year of age. It starts from 2 months and lasts till 1 year of age. The involuting phase means it is slowly resolving. It lasts till 5 years of age. Whereas the involuted phase, it has completely resolved and it lasts till almost 12 years of age. Whereas the congenital hemangioma, it is completely developed at the time of birth. So when you will see the patient, you will see a completely formed tumor. So it is completely developed at the time of birth. It do not pass the pathognomonic phase of this infantile hemangioma. That is, it does not have proliferation phase, involuting phase, or involuted phase, because the lesion is fully formed. Here male and females are equally affected. The types are rapidly involuting, non-involuting, and partially involuting type. The hemangioma which are associated with syndromes are Face syndrome and Kasabach-Merritt syndrome. These are the few syndromes where we can find hemangioma also. So the first and the most important step in the management of vascular lesion is to determine whether the vascular lesion is a tumor or a malformation, as I've told earlier. So you have to understand whether it is a tumor or whether it is a malformation. If it is a tumor, determine whether it is proliferating type of tumor or involuting type of tumor. And if it is a malformation, you have to determine whether it is a slow flow lesion or a high flow lesion. So indications for treatment of vascular tumors. Tumors will have to be treated if it is well localized, if it is ulcerated, if it bleeds, if it is causing some kind of airway obstruction, if it is interfering with the vision of patient, and if it causes facial feature distortion. Now coming to treatment option of vascular tumors. These are all the treatment options of vascular tumors. After this we will study about vascular malformation. For vascular tumors we have some medical therapy and some surgical therapy. The medical therapy includes intralesional steroid injection. They mainly block the vascular endothelial growth factor. If the vascular endothelial growth factor is blocked, then obviously there will be less tumor hyperplasia. The dosage will be 3 mg per kg once a week for 6 weeks. Then we can give systemic corticosteroids also. They block vascular endothelial growth factor again. They have same mechanism of action. They are used for destructive function impairing or life-threatening lesions. Then we have interferon alpha. The cases which are unresponsive to corticosteroids, and so in such cases we have to give interferon alpha, and they inhibit endothelial cell proliferation and they also inhibit angiogenesis. The dosage is 3 million unit per day subcutaneously up to 5 months. Another medical therapy is beta blocker injection or propranolol. They induce apoptosis in endothelial cells. They are given 1 mg per kg once a day for 6 months. So this is a potential MCQ. Just remember these points. Beta blocker, example propranolol, which we give for vascular tumors. We give interferon alpha. Remember these points. Propranolol, it is a kind of beta blocker. Interferon alpha. Then we have intralesional steroids and systemic steroids. These are the various medical therapy for vascular tumors, not malformations. I am saying only about vascular tumors. Coming to surgical therapy, surgical excision can be done for those lesions that are not responding to medical therapy. Then staged resection. They are used for labial hemangioma because they can cause distortion in 3 dimensions. The mass is first of all debulked by excision of mucosa and submucosal tissues, and later on the vermilion cutaneous junction is excised. Now we have come to vascular malformation. The first step in the care of patient with vascular malformation is to determine whether it is a slow flow lesion or a high flow lesion. Complete resection is not possible in most cases because there is chance of bleeding, increased bleeding, which can lead to death. So very careful scrutinization is important. Okay, so complete resection is not possible in most of the cases. The slow flow lesion without intrabony involvement cause secondary bony distortion due to bony overgrowth. They can grow within the bone also, okay, intrabony lesions. The fast flow lesion usually produce bony destruction, okay. So what are the indications for treatment of vascular malformation? We treat them when there is increase in the size and increase in swelling, if it is associated with pain, bleeding, if there is infection. When it is involving the tongue, it can lead to macroglossia of the tongue. It can also lead to feeding difficulty if it is present in the tongue or in the retropharyngeal space or in the parapharyngeal space. It can cause bony destruction leading to distortion of the or disfigurement of the face. It can also lead to airway obstruction. So these are the few indications for treatment of vascular malformations. Let's look at capillary malformation. Capillary malformations, they appear as pink spot. They were formerly termed as port wine stain. These terms you must have heard, or must have seen in your textbooks. Port wine stain. Port wine stain is basically seen in capillary vascular malformation. They appear as pink spots, and they specially spread along the trigeminal nerve. The associated syndromes with capillary malformation are Sturge-Weber syndrome, Klippel-Trenaunay syndrome, and Parkes-Weber syndrome, or also known as Proteus syndrome. Just remember these important syndromes for MCQs. Treatment option for capillary hemangioma are pulsed dye laser, excision and skin graft or skin flap, then orthognathic surgery if there is bony distortion. Now coming to venous malformation. Venous malformation is the most common type of vascular malformation. Again, it is a kind of potential MCQ. Which is the most common type of vascular malformation? The most common vascular malformation is venous malformation. It increases in size when venous pressure is elevated or during crying. It is characterized by presence of phleboliths. That is, it results from gradual calcification of the clotted vessels in venous vessels. Here you can see the patient having venous malformation of one side of the tongue. Treatment option for venous malformation: sclerotherapy, excision and resection. And the sclerosing agent of choice will be ethanol. It is again a one MCQ. 100% ethanol is the sclerosing agent of choice for venous malformation. It produces endothelial damage that results in permanent endofibrosis and obliteration of the vessel. Excision and resection of the localized lesion, not tumor. Coming to lymphatic malformation, they are classified as macrocystic or microcystic. The macrocystic malformation are called cystic hygroma. This is the case of cystic hygroma. They occur below the mylohyoid line, or they occur below the mylohyoid muscle in the neck, mostly seen in front of the sternocleidomastoid muscle. And the differential diagnosis for cystic hygroma is what? It is again one MCQ. The answer is plunging ranula. Okay. So plunging ranula is a differential diagnosis of cystic hygroma. So cystic hygroma is basically a kind of macrocystic lymphatic malformation. Then we have some microcystic lymphatic malformation. They commonly involve the tongue, cheek and the lips. This is a case of microcystic lymphatic malformation. Coming to treatment options for lymphatic malformation, we have sclerotherapy, and which is the most commonly used agent for sclerotherapy for lymphatic malformation, that is picinabel or OK432. Okay. Then we have excision of the lesion, stage surgical excision for large lesions, and orthognathic surgery if there is any kind of bone involvement. Coming to arteriovenous malformation or AV malformation. AV malformation is the most dangerous. It is the most dangerous subtype of vascular malformation. The most common one was what? The most common one was venous malformation, and the most dangerous one is AV malformation. It consists of needles that is composed of abnormal capillary system. It appears as a red tumor with elevated temperature and typical palpable pulsation. It is associated with arterial steal syndrome. Intraosseous lesions, mostly malformation and hemangioma. Okay, now coming to staging of the arteriovenous malformation. According to Schobinger, he classified or staged the arteriovenous malformation into stage 1, 2, 3 and 4. Stage 1 is the quiescent stage. A bluish skin blush is present. Stage 2 is the expansion stage. A mass which is associated with a bruit and a thrill is present. Stage 3 is the destruction phase. A mass associated with ulceration, bleeding and pain is present. Stage 4 is decompensation phase, where the lesion produces heart failure. That is, it is the end stage. Coming to treatment option of AV malformation, the treatment option is arterial embolization. The embolizing material can be temporary or permanent. The temporary embolizing materials are gel foam, collagen and iodine. The permanent embolizing materials are platinum coil, acrylic glue, silky thread and stainless steel. So these are the references, and I hope this lecture was very much useful, and it is a very important topic. So I hope you all got to learn something new. If you have any question, just put it in the comment section. I will try to answer your queries. Thank you all for listening.